We're here at the 25th CROI in Boston, and we're here with Natella and Adeline, and they are going to be presenting on, actually you just were in front of a poster that we looked at and said this is pretty important stuff.
Yeah.
So there's 700 posters. There's probably maybe, 10%, maybe less, that are in pediatric, and that is important. That's what your goal is. You're with EGPATH, and you are?
I'm with Johns Hopkins.
So I'll let you further introduce yourselves so that the audience can know who you are and who you represent.
Sure. My name is Natella Rakhmanina. I am a professor of pediatrics at George Washington University and practice pediatric HIV infectious disease in Children's National Medical Center in Washington, D.C. And I also work as a senior technical advisor for Elizabeth Glaser Pediatric AIDS Foundation.
My name is Adeline Koay. I'm a third-year postdoctoral fellow at Johns Hopkins University, and I work currently doing some research at the Prasad lab and also doing clinical work.
Great. Well, I think the first thing we might want to do is kind of cover the poster that you presented, and so that you can give us a little background on that.
Sure. So I have taken the last couple of years to look at the relationship between inflammation in babies that have HIV and whether or not there's a relationship with the gut barrier, because we feel that there's been a lot of data that's hypothesized that the gut microbiome, or the bacteria in the gut, could be important in the persistence of inflammation in babies with HIV. It's been shown in adults, but we don't know as much what this relationship is with babies. And I studied a population of babies that were both HIV positive and also babies that were born to mothers with HIV, but they themselves were uninfected. And they were shown to have significantly increased inflammation in the HIV-infected babies. I also looked at whether or not the gut barrier was different, whether it was damaged in HIV infection. And interestingly, at 3 months of age, there was no difference between these two populations, whether or not you are infected or not infected. There seems to be no difference in how damaged the gut barrier actually is. At 5.5 months of age, one of these measures of the gut barrier seems to go up actually in infection, and then in the uninfected infants it goes down. So it seems like there's a complex relationship between HIV and the gut barrier, and we're hoping that in the future we'll be able to study the microbiome and see whether or not that is actually different in HIV-infected infants.
And the gut is where most of the activity, HIV activity, is happening.
Absolutely.
So with that in mind, I guess it's why it makes sense to be looking there. And as we've talked many times over the years, that anything that we learn in the adult population is not automatically presumed to be accurate or repeatable in the pediatric population or adolescent population. So those bits of research have to be relearned or re-examined, and that's what you all do.
Absolutely.
And I appreciate it. So what is the next steps on the work that you're doing? What would you?
So right now, since we've shown that one of the markers of gut integrity may be actually increased in HIV, we think that there is like I said before, a complex mechanism as to how the gut barrier might be breaking down. So the next step is to look at whether or not the gut microbiome actually does change between HIV infection versus no infection. Because we know in the adult population that a lot of data has suggested that actually there is a change in the microbiome because of infection. But we don't know if that happens in babies. And if it does, that could explain why infants actually have inflammation as well.
How do you examine the gut biome?
Yeah, so that's a really good question. So we have to collect stool, or in certain populations, if you have access to gut biopsies, but obviously we're not going to be doing that in young children. And you get the stool and you extract DNA from the stool. And we do something called 16S rRNA sequencing. So 16S is something that is unique to bacteria. And we sequence this 16S and identify what bacteria is actually in the stool. And then do lots of very complicated statistical analysis to figure out whether or not a certain bacteria may be enriched or depleted in the stool.
Sounds very complicated.
It is very complicated, yep.
But how assured are you that you're getting the results that you believe you're getting?
So that's a really good question too, because one of the limitations of our study is that we don't have a good control to compare our participants to. And by that I mean that we don't have a population of infants that were born to mothers without HIV. We know that HIV exposure, even if the baby is not infected, can have a significant impact on the outcomes of the baby. For example, you still have low weight even if you are not infected, but if you're born to a mom with HIV, you still have changes in your vaccine responses, and you may not have as good health outcomes compared to babies that were born to mothers without HIV. So we are lacking that. That's one of the limitations. So it's difficult to know exactly what the whole story would be. That said, I think that this is a good preliminary to give us some data about what's going on, and it helps us to be able to move forward to study it a little bit more.
So I appreciate your work, and I wanted to get to Natella Rakhmanina. We're interested in knowing the big picture at the CROI. And I don't know if you have some things in the back of your mind that you'd like to say that happened here that were worthy of discussion at this point, or bringing it up. And
I do believe we're pleased as pediatric community and mother-child community with a focus on certain areas of research at this CROI conference. CROI always finds time to put us on the agenda, and this year I think we have met several goals that are really important and relevant to us. There are 1.5 million women in the world who get pregnant each year with HIV, and we are seeing a decline, steady, continued decline, not yet to the elimination range where we'd like to be, but continuous steady decline in the transmission of the virus. But as we look at it, we still are realizing more and more the long-term impact of the exposure in utero while the baby is still in the maternal womb, during the labor, delivery, and postpartum after the baby is born, both to HIV at every level, from psychological level, neurodevelopmental aspects, to the level of microbiome that Adeline just discussed, through the breastfeeding period, because the current recommendation is to breastfeed children up to 2 years of age. And during that time, the babies are exposed to the drugs that they receive for prophylaxis themselves. They're exposed to the drugs to the mother is taking to treat her HIV. And there is a lot we start looking, there are a lot of aspects of maternal health and child health and long-term health, the one that Adeline just alluded to. We are not looking at the first few months of life, we really want to know the long-term impact. From that perspective, that's been a really good conference for us. We're really pleased to have had already, by the second day, 2 significant sessions on that subject. We have had session designated to the microbiome and gut in children. We have had session designated to the breastfeeding issues. From anywhere from the penetration of the drugs to the breast milk, which was brilliantly presented by the group from Liverpool, to some immunological aspects. We are learning more and more interesting aspects of how there is immune activation that's going on both ways. It's a mutual process of breastfeeding where the mother's body and mother's immune system is reacting to her baby and equally. And this is becoming more and more focus of our work. We feel that the cohort of HIV exposed infants, children, and adolescents down the line deserves more attention from the point of view of research. We need to know more. We also are transitioning to a lot of new therapeutic modalities with mothers. We discussed here, and there are sessions dedicated to transitioning first-line regimens already in 20 countries to dolutegravir-based, which will lead eventually to the introduction of new drugs into pregnancy and breastfeeding period. And we still have quite few unanswered questions in that field. So looking forward, and the PrEP is being scaled up. That means that even the HIV non-infected women who will take antiretroviral medications to protect themselves from HIV, the number of these women is expected to grow globally. There are quite few sessions at this CROI specifically talking about scaling up PrEP or pre-exposure prophylaxis with HIV medicines in women. We have placed a great emphasis on MSM population in the past, which is wonderful, but we do realize women lag behind. So with this, we'll increase the number of women who will be taking medications during the pregnancy and throughout breastfeeding period, which again will be very relevant to the cohort of women who live with HIV. So if we're now talking about 1.5 million women who are pregnant each year, that number will be gradually increasing, and depending on the speed of our scale up of PrEP globally, that number can really be very exponential. And we want to be prepared to handle the issues of knowing what is exposure both to medicines that applies to infected and non-infected, and among infected women to the virus has effect, what kind of effect, and what can we modulate this effect. For example, from the very, very breakthrough research that Adeline is doing in the lab of Dr. Prasad, is there something we can do early on, in addition to breastfeeding, to modulate baby's immune response? We don't have answer. Would probiotic help or harm? We don't have answer. So we're doing this research with eventual goal to improve the health outcome of babies who are exposed to HIV and antiretroviral drugs. We just need to know where and how we can move this improvement forward. And as Adeline alluded in her discussion, indeed, we do know as of today that the babies who are not infected with HIV, but who have been exposed to the HIV in the mother's body and during breastfeeding and to her medicine, we do know there are certain health parameters that set them aside from healthy children who have never been exposed to HIV, and we want to have answers. What are the reasons, and how to make sure we can leverage that influence or prevent it?
The thing that I've always been astounded by is the fact that we've always been on again for the breastfeeding, then off again, on again, off again. And it's interesting how there was like profound conclusions that, oh, we're never going to do breastfeeding. But then it comes back. Can you give the brief history of that at all? Or?
Absolutely. We started, when we started working on preventing mother-to-child transmission, the fact that breast milk can transmit HIV has become quite evident quite early on. And we did move on the first in the resource-rich settings where formula is readily available, very quickly moved on saying no breastfeeding, and then consequently moved on saying this in a global format. However, there is a huge difference in access to the safe water between the resource-rich settings and resource-limited settings. And once we started scaling up the recommendation, do not breastfeed in resource-limited settings, we realized that a lack of access to safe water, in fact, the risk associated with formula feeding children with unsafe water was greater, and the risk for their morbidity or getting sick, or mortality or dying from gastrointestinal infection and dehydration was actually higher. So that was a major component in our assessment, and we saw it quite early on, where we started going back and reevaluating our recommendations. And that's where the modalities of using the antiretroviral drugs actively around delivery time, postpartum, treating women, treating babies, and there we've gone through some modalities. We put a lot of emphasis of giving drugs to baby initially, then we put more emphasis on giving drugs to mom. I think we now still are in finding the right balance, because we have very effective therapy in moms, but we do know that women face a lot of barriers to adherence after they had the baby. And Therefore, WHO in recent years again went on enhancing a bit more the prophylaxis we give to babies, particularly babies in a high-risk scenario. So we are still trying to find an eventual balance. And I think in this sense, research in the fields like neutralizing antibodies or anything that long-term will assure the protection of the baby in case mother is unable to maintain a very steady adherence, or finding the modalities of long-term antiretrovirals for both mother and the baby become very relevant to us. So it's still a very challenging field, but the breastfeeding currently is recommended by World Health Organization in a global settings up to 24 months of age, which is 2 years. We also are seeing a lot of discussions around breastfeeding in resource-rich settings now. We, for so many years, have recommended exclusive bottle feeding, formula feeding, and we continue to recommend exclusive formula feeding. But we are having a growing number of women who have been on antiretroviral therapy for a while, who have very suppressed viral load, and the question arises whether there is a possibility for them to breastfeed their children here if they desire so. So I think we have not yet come to real consensus on this issue. We do know that we reach consensus in the fact that we really need to take in consideration more the woman's desire and have a more open dialogue with her, even in resource-rich settings where formula is readily available, because we cannot just be prescriptive, forbidding her to experience that in her life. So there is a lot of debate, and there was wonderful discussion held today by the perinatal hotline during daytime as a satellite discussion among the providers in North America, European providers, discussing how to handle this issue here. But in a global settings, there is no question we need to find better modalities to support women throughout the period of breastfeeding with her own treatment and protection of the baby.
And education or information on the pros and cons, and then, at least at this point, make decisions based upon good information.
Absolutely. Yeah. And we heard wonderful examples today from the investigators and in the sessions about Botswana studies. I mean, there is really a lot of experience building up and wealth of knowledge. We probably don't have a universal solution yet, but we are advancing. And in this sense, research by young people like Adeline really looking into the very complex relationship between mother's body overall as a holistic approach and baby's body with, without medications is very, very important to move this field forward.
Now, are you a young investigator? Would you still call yourself a young investigator?
Well, I'm an early investigator in the field of HIV.
But not.
Maybe not as young as I would like to be. Yeah.
Well, no, we've been interviewing a number of young investigators and early investigators. I like that one, early investigators.
Yep, not a young.
Well, there's a lot.
Well, it leaves the rest of us on a very unfavorable side
no, not
of this.
necessarily. You're not there yet. I am. But there's a lot of people who are retiring. And we really are concerned about the cadre of new blood in the field. And I'm not afraid of that, but I think it's always worthy of letting people out there know that there are people in the field that they could be one of them. They could be one of those folks. And I don't want to couch anything here because I know that it's a difficult field. It's probably the most challenging field in the world. But if that's what you're looking for, you'll find it here, right?
Yep.
Would you not agree?
I agree.
Yeah. All right. Well, thank you both very much for being here and
Thank you.
imparting your words of wisdom in the field of pediatric and AIDS.
Thank you. Thank you for giving us opportunity to talk on this subject. Thanks.